Hello everyone, we'll be starting our webinar now. Thank you for your patience. Today we have gathered here for the webinar on Beyond the Birth Certificate, Unlocking the Genetic Blueprint through newborn screening. So I'll be inviting our moderator of the day, Dr. Deeksha Bhartiya, the founder and director of Genomiki Solutions Private Limited. So I'll be handing over the mic to her. On to you, ma'am.
So, thank you everyone for joining in. Thank you, Anchal, for the introduction. It's my pleasure that we are going to start this the first chapter of our webinar series. Good afternoon, everyone, and a very warm welcome to the first chapter of our webinar series, which is Beyond the Birth Certificate, Unlocking the Genetic Blueprint through Newborn Screening. So, through this initiative, we aim to gain a deeper understanding about newborn screening, how early detection of rare disorders, many of which are actually silent at birth, can enable timely intervention and help reduce potentially irreversible damage. We are so glad that you have all joined us today. We also expect a lot of other registered participants who have registered for this webinar to join us gradually, but because we have to start everything on time. We are going to start it right now. My name is Dr. Deeksha Bhartiya. I'm the founder and director of Genomiki Solutions, and I'll be your moderator for this session. So we kindly request you to fill out the feedback form after the session, so that which will be sent to your registered email address at the end of the webinar. Do share your comments on our YouTube channel and follow us on LinkedIn and Instagram for future updates as well. So now let's begin, and it's my absolute pleasure and honor to introduce our speaker for the day, Dr. Priyanshu Mathur. So Dr. Priyanshu Mathur is currently the professor at Department of Medical Genetics, SMS Medical College, Jaipur, and he is also the State Nodal Officer for Rare Diseases for the state of Rajasthan. He is a renowned consultant in the field of pediatric rare and metabolic genetic diseases. He's the gold medalist in MBBS and MD Pediatrics, and have pursued advanced training in metabolic genetics and newborn screening at Emory University. So with over 50 publications, authorships of key texts like Rare Disease in Pediatrics, and countless invited talks to his name, Dr. Mathur is a passionate advocate for early detection, precision medicine, precision therapies, and policy reforms in rare genetic disorders. He's actually one of the advocate person to host the first session, or to speak about at the first session or the first chapter of our webinar series. And it's my pleasure again to invite him on this forum. So Dr. Priyanshu, thank you for joining us today. Can you please share your slides, and let's begin about your introduction about human training. Thank you.
So thank you very much, Deeksha, for the kind introduction. And thank you very much for inviting me for today inviting me for this such an important topic. So I'm just sharing my slides.
I request all the attendees to keep noting down their questions, and they can also share their questions in the chat box. We'll be happy to take their questions at the end of the session.
I hope my slides are visible.
Just give them a second. Yes, now they are. So yeah, please proceed.
Thank you.
The stage is all yours.
Very much. So today I'm going to talk about unlocking the genetic blueprint through newborn screening. So this is a very important topic. Nowadays, the parents and the entire community should learn about what is beyond the birth certificate. So that is newborn screening. It is a very, very important topic. So a child receives a birth certificate. What else can we know at birth? So a few slides about the genetic disorders. So genetic disorders that affect a small percentage of the population are often classified as a rare diseases. While the exact definition of rare varies by region, these conditions are generally marked by low prevalence inherited origin, and significant complexity in both diagnosis and treatment. So the current definition of rare disease varies from different countries and from different organization to other organization. So according to WHO, when a disease affects less than 1 per 1,000 population is considered as a rare disease. By this definition is given by the WHO, and in other country the definition varies. Like in few country it is less than 1 per 2,000. In India, we consider if a disease affect less than 1 in 2,500, we call it as a rare disease. So the average number of patient varies. Average number of patient globally is around 300 million, and it is seen that around 30 million of the US population is suffering from one or other genetic disorder. Similarly, 30 million in European Union. In India, few states have reported highest burden. These states are Uttar Pradesh, Maharashtra, and Bihar. And according to current data, it is estimated that 7 to 8 crore crore of total population is affected by one or other rare disease in India. So, because we are having very huge population, so around 25% of the rare disease patients, global patients burden is in India. And there are around 7,000 to 800 disorders which are classified as a rare diseases. 70% of the rare diseases are having genetic etiology, 70 to 80%, and 95% of the rare disease patients does not have any approved treatment options for them. And it is seen that around 4.8 years is the average time taken to diagnose a rare disease patient, and the maximum time taken which is reported is around 20 years to diagnose a rare disease patient. So, so I'm giving example of common genetic disorders in newborn. So the common disorders are phenylketonuria. The prevalence of phenylketonuria is 1 in 10,000 to 1 in 15,000 births. Next is maple syrup urine disease. It is seen in around 1 in 185,000 births. Sickle cell disease is seen in 1 in 250 to 1 in 2,500 births. It is more common in Africa and India. G6PD deficiency is very common. It is seen that it can be present in 1 in 118 in India, and thalassemia major types is 1 in 10,000 births globally. Carrier rate is up to 1 in 20 in India and Mediterranean regions. But these prevalences are current estimates when we are not having newborn screening in place. It is expected that in future, when there will be a robust newborn screening program across the country, these data can change and we can find more number of patients. So, so as I already told, that majority of rare diseases are genetic origin, and 70% of these diseases starts in childhood, and 30% of these patients die before they are 5 years of age. So burden of different rare genetic disorder in India. So this graph is showing the proportion of total diagnosed cases by disease group. So inborn error of metabolism. So there are around 7,000 to 8,000 rare diseases, and it is estimated that around 80% of rare diseases are genetic of origin. Out of this category, there is a major category which is known as a inherited metabolic disorder or inborn error of metabolism, which includes around 2,000 disorders. So out of these 7,000 disordered, around 2,000 disorders comes under the category of inherited metabolic disorder or inborn error of metabolism. This is a very important class because in this class there is either deficiency of enzyme or transporter or receptor. So this category is considered a potentially treatable category because it will correct the enzyme deficiency. We treat the receptor defects or we treat the transporter defects. We can give them a better quality of life. So and the majority of patients which were reported are inborn error of metabolism. Second category is neuromuscular and neurodegenerative disorder. It's a second common category. In this category, there are spinal muscular atrophy, Duchenne muscular dystrophy, limb-girdle muscular dystrophy, Ehlers-Danlos muscular dystrophy. All of these conditions comes under this category. And recently, there is a very effective treatment which is available across the globe and even in India for spinal muscular atrophy. And lot of research is ongoing for DMD and LGMDs. Then hematological disorders, pulmonary disorders, followed by musculoskeletal disorder, dermatological disorders, then congenital hearing loss, which is again a treatable condition, ophthalmic diseases, endocrine disorders, hepatic disorders, or then nephrological disorders, which primarily involves kidney, mitochondrial disorders. Mitochondrial disorder again comes under category of inborn metabolism, then cardiovascular causes and immunological causes. So these are the common diagnosed cases by disease group in India. So why newborn genetic screening matters? So for this, we need to understand the hidden carrier risk. So if both the parents are healthy carriers of the same genetic condition, there is a 25% risk of having a baby with the genetic disorder. So this is an example of cystic fibrosis. So when a cystic fibrosis carrier female marries with a cystic fibrosis carrier male, they can have four different combinations in their offspring. So 25% of the offspring can have a both the gene copy defective from which comes from either parent. Then the 50% of the babies can be carrier because they can have a normal copy and another defective copy, and 25% of their offspring can be normal because they can have both the normal copy, even both the parents are carrier, then also there can be a normal offspring. So this is very important because it helps in the prenatal diagnosis and genetic counseling also, and to prevent the recurrences in subsequent pregnancy, and or by different methodology like IVF or embryo transfer, we can prevent the recurrence of genetic and metabolic disorders in subsequent pregnancies. So about genetic disorders, the majority of genetic disorders have silent onset. At the time of newborn life, they usually don't have any symptom. When they grow up, they can slowly develop symptoms. They can have a countless doctor's visit. I will give an example of MPS2, mucopolysaccharidosis 2 patients. At the time of birth, they are entirely normal. Then they develop recurrent diarrhea, they develop recurrent otitis media, they can develop hearing loss, they can develop coarse facial features, they can have hernia. For that, they can undergo surgical correction also. So they can have a countless doctor visit, and condition getting worse due to no early identification and treatment. And later on, whenever we are diagnosing these patients late in the life, then there is a higher treatment cost and maintenance cost if with the poor result. So they need to travel very long road for diagnosis. On average, it takes more than 4 years before a correct diagnosis is made. As a rule, more than 8 doctors are consulted, and 40% of patients are misdiagnosed on at least one occasion. So now about economic burden of rare diseases. So This is a estimate which was done in US in 2019. They found the total economic burden of rare disease in the US is around 966 billion, which is very huge. So the different category where this economic burden pose a significant problem for economy is include transportation cost, inpatient treatment cost, absenteeism for work, presentism at work. Few of the caregivers or patient, they are present at work but they are not productive. Then the expenses can go under the forced retirement, outpatient treatment administration, uncovered healthcare costs, social productivity loss in volunteer work, treatment procurements, necessary auto modification. I will give an example like for DMD patients, parents need to modify their car or they need to modify their vehicle so that they can take the baby to hospital for visits, and uncovered healthcare costs. Then home modification, people need to modify their home to meet the daily needs of the baby or patient. So all these contribute to the economic burden for rare disease patients. Then what is newborn screening? So newborn screening we can do newborn screening by collecting few drops of the blood on a special paper that is known as a filter paper. We can send this sample for analysis. Then they can generate the metabolic or genetic report in the lab, and find we can after that report, if it is positive, we can go for a confirmatory test, and we can make the confirmatory diagnosis followed by the treatment. Despite its simplicity, newborn screening is highly sensitive and accurate. I just want to add that newborn screening has multi components, so multiple components, and newborn screening is of various type, like hearing screening, ROP screening, retinopathy of prematurity screening, then critical congenital heart screening, blood spot screening. So this slide is mainly focused on the blood spot screening, which can diagnose more than 50 disorders by a simple 3 to 5 drops of blood. So why should we screen newborns? So because early detection can save many lives. Early detection helps in the early or normal development. We can support the development of these babies. Most affected babies look healthy at birth. It is one test which can give many answers, and it empowers family and clinicians. So I just want to add that the small there is a category of inborn error of metabolism which comes under a broad category of a small molecule disease. So these small molecule disease patients can be entirely normal in between, and whenever they develop symptom, they land up into the ICU care, or they land up into the emergencies. They land. We can treat this patient at the time of emergency, and again we can send these patients home. In between the two episodes of these critical illnesses, they can be entirely normal. So if we'll treat these patients properly, and we can have normal development in these babies. But for that we need to identify and treat these babies at the right time. So this is a case study. So 3 weeks, 2 days female baby, and the newborn screening was done for this baby, and a gene which is known as a POMC gene was identified. The variant was likely pathogenic. So diagnosis was confirmed by confirmatory test, and treatment was started for this baby. And this baby showed a significant improvement after starting the treatment and had a better quality of life. So India's initiatives in genetic screening, they are national efforts towards the early genetic diagnosis. So Rashtriya Bal Swasthya Karyakram, which was launched under the National Health Mission, aims to screen children from birth to 18 years for more than 30 plus health condition, including birth defect, developmental delay, and genetic disorders. This Karyakram mainly focuses on early identification and intervention at the district level. Next is Nipun Bharat, an early childhood care program. While not directly genetic, these platforms integrate developmental milestone screening where genetic testing could be linked in the future, opens a pathway for genomics to become a part of child wellness tracking. Then the state level newborn screening initiatives. So Tamil Nadu, Kerala, Maharashtra, Delhi, Chandigarh have initiated or piloted newborn screening programs for disorders like congenital hypothyroidism, G6PD, and severe combined immunodeficiencies. And public-private partnerships are helping expand scope and scale. So what needs to be done? So the most important is to increase the awareness and education, which we are doing by doing today's webinar. Second is policy and regulation. Then every child should be screened at birth. Parents should be screened before the conception. Like for hemoglobinopathies, we can screen parents if both the parents are carrier of thalassemia, they can have 25% chances of having baby with the thalassemia major. So thank you very much. We can now we can have a question answer session.
Yeah, first of all, thank you so much, Dr. Priyanshu. This was a very insightful presentation. Your talk has actually emphasized that our birth certificate alone is not enough, which is the title of the talk today. And we must also strive to understand the genetic blueprint every child is born with, and what are the major the challenges and what are the major reasons that we should be going through newborn screening. We have also gotten to understand that the silent burden of rare genetic disorders, often because they go unnoticed at birth, only to later cause significant health and emotional consequences and also financial strains for not just the families, but that amount of financial burden that you showed is a complete burden to the entire society. So I'm really happy that we could bring that out through your presentation. Because we wanted to make this discussion very interactive, we have prepared a couple of questions that we would like to ask you so that you can take us through various sides of newborn screening. First of all, I would like to congratulate your efforts in creating awareness about newborn screening and to be the one of the stalwarts and pioneers in creating such awareness. And also congratulating you on the updated list which has been provided by ICMR yesterday itself, where they have added newborn screening in the national essential test list. So, what are your thoughts about this?
Yes, so it's really great that ICMR included tests for newborn screening and inborn metabolism in their national essential test list. This can bring a significant change, as we all know that India is moving towards from developing to developed country. So the goal of having a developed country by 2047, which is a vision of our central government, so that can be fulfilled only when we can give the uh, when we can further decrease the infant mortality and morbidity, and we can give the benefit to the last least privileged society of the country. So by that, by including these tests in the essential test list, we can have different centers where these tests can be established and started, because as we already discussed that policy is very important to implement any program. So I think this will be a significant milestone for country, and it will really help in the decreasing neonatal morbidity and mortality.
Yeah, that was a wonderful thought. And given your experience with these grassroots initiatives, because the government is now trying to include newborn screening in essential test list, and many of the state governments are also promoting this. So, what are the challenges that the government faces when raising awareness about newborn screening?
Right. So there are few challenges. The first challenge is geographical and cultural diversity. As we all know that India is having huge population load. So we are having different backgrounds, cultural diversity, and different languages. So that is a bigger challenge. Second is healthcare priorities. Still, India is fighting with many infectious diseases, and we are still fighting with these infectious diseases. So we are having different healthcare priorities. Then government, there is a urban rural divide also. So majority of healthcare facilities are now well established in for urban population, but still we are facing difficulties in giving healthcare services to rural population. Then lack of uniform policy, because as you already mentioned that many states they are having their universal newborn screening program in place, but there is no program, no policy at the level of central government. They included these tests in the essential test list. I think this can be followed by uniform policy for entire country. Then training of healthcare workers. So if you will see the contact person for majority of families in India is ASHA workers or grassroots level workers, and we are not training these healthcare workers, so they can't counsel. If somebody asks them what is the importance of newborn screening, so it's very difficult for them to counsel this family that whether they should opt it or not. So that is a bigger challenge. And then cost perceptions. So majority of people having perception that it's a wastage of money, and the cost involved in test is not uh, worthful. Okay, so this cost perception is again a problem at the level of even government or at the level of families. So these are few challenges which I see.
Yeah, exactly. You actually have summarized all the challenges in a very structured and accurate way. And but still, many states are doing great work in these in newborn screening initiatives. So, according to your understanding, which state or region in India is actually setting a benchmark in these
Right.
initiatives?
Right. So definitely Kerala is setting a benchmark in India. So they have their program in place, Shalabha. So they have a universal newborn screening program in place, and they are running it fantastically. So they are also having very good follow-up protocol for these patients, and they are also having very good management protocol for these patients. So Kerala is doing good. Apart from Kerala, the Goa, Delhi, and Chandigarh, they are also doing good work. Delhi, they are running a project Neve. Under that project Neve, they are doing newborn screening. And similarly, Chandigarh and Goa also, they are having their newborn screening program in place.
Yeah, of course, yes. And in fact, at this point, I would also like to ask you that as an organization or as a startup, we are working in this space as well. So, what kind of innovations or what kind of products do you need that we should be developing in this particular space, and how we could actually support these efforts, not just in a private manner, but also how can we support the government, the state missions?
So in current scenario, the most important is digital campaign. So you are running digital campaign that's really very important because majority of people across the country are having very easy access to mobiles and other digital devices. So the digital campaigns are very important. Second, developing IEC material. So IEC material should be in local languages for different region of the country, and then you can organization like you can get engaged with the healthcare professionals. You can educate healthcare professional also, and you can provide the latest information to healthcare professionals so that they can percolate their knowledge to the families. Then community outreach. So community outreach is very important. uh, Organization like Genomiki and other organizations, they can tie up with NGOs, those who are having their presence in the society. Then last, CSR funding, CSR corporate social responsibility funding can also help in bringing change in society.
Okay, yeah, sure. Definitely, startups or companies like us should be focusing more on creating awareness and helping the state missions and other missions so that we can percolate or we can educate these healthcare workers and professionals. So, in fact, you also mentioned earlier about the National Policy for Rare Disease 2021 under the newborn screening recommendations that there are particular set of disorders. Could you elaborate on why the disorder about on the disorder that are actually not covered under the policy? What criteria are used to exclude them, and why only 63 or 64 disorders are included?
Right. So this national policy was formed in 2021, and after that there were the total number of disorders which were included. So there were few deciding point on these disorders were included. The first and foremost was availability of treatment. So those disorders who are having definitive treatment which is available, and for disorders for which we are having DCGI or CDSU approved drugs available, or definitive treatment guidelines are available, only those disorders were included initially. Okay, but we are expecting that over a period of time, more and more disorders will be covered in national policy for rare disease 2021. The second important is there is data. Data is very important. So the disorder for which the treatment which are available have shown the significant improvement in their conditions. So the national policy mainly focused on the curative therapies like organ transplantation or therapy which are having a significant benefit in patient condition, like for small molecule diseases we are having a lot of treatment options available. Okay, and next important is definitely cost of the therapy. So for few disorders therapies are available, but these therapies are having so exorbitant cost that government can't uh, pay for it right now, but we are expecting that in future this policy will expand to the other disorders.
And when you say that these disorders have treatments available, does that mean that the treatments are available within the country or they have to travel to other countries for getting the treatment?
So NPID covers only those therapies which are available in the country. For that, Government of India released a gadget notification in June 2020, and that gadget notification clearly mentioned that the for any drug which can be used in country for mass level, and so the safety and efficacy of that drug should be established in trials. The drugs which are not approved by Government of India, CDSC or DCGI, these drugs can't be used at the level of doctors. So, but family, they can procure these drugs from any country if it is shown a significant benefit and it is approved in other countries. So only families they can import these drugs, but doctors or any healthcare organization they can't import these drugs.
Got it. So, since you have mentioned about families, so let's shift our focus on now to the most important part of newborn screening. Because since you are also a practicing pediatrician, you might also be in frequent touch with parents of the children who are suffering with such disorders. So, let's talk about parental consent. So, is parental consent required for newborn screening, or is the process state authorized wherever there is a state newborn screening policy?
Right. Okay. So currently in India, informed parental consent is a standard and necessary practice. Okay. But in few country, Western country, where the NBS is a state mandated program and they are having opt-out program. The meaning of opt-out program is it is essential for all the newborns in few countries. But if parents want to opt out, they need to give consent to opt out. But currently in India, it is opt-in process currently because there is a no uniform policy across the country and even the state policy. So patient, we have to take consent to if patient want to opt in. We need to counsel them about the purpose, benefit, and process of newborn screening, and we should get the verbal or written consent.
And when
Verbal
you
consent is sufficient, in my view. Verbal consent is sufficient.
But in when you talk about consent, so this consent is before the birth of the child, or I mean, or after the child newborn is
So
there, and within the
when
first few hours. Yeah.
when we are collecting the sample, before that we need to take the consent.
Okay. And then when you talk to these parents, so you must come across all sorts of presumptions and concerns from the parents of these newborn children who are apparently healthy. There must be a lot of new information for them to process, because you just mentioned that you have to counsel them and tell them that what exactly you are doing. So can we address some of them in this discussion, that how do you
Yes.
actually do that?
Yes. Okay. So for your previous question, I just want to add one more point. There is a term is implied consent. Implied consent mean if any father or mother is paying for newborn screening, so that implies that they are giving the consent. So newborn screening in private sector, majority of parents are paying by their own pocket. So that includes implied consent. And the concerns of parents include like pain. That's the most common concern. My baby will get the pain. Second concern is fear of blood draw. Fear of blood draw. So third is why we are testing healthy baby. So that's the third concern. Fourth concern is potential harm. So potential harm that if we are pricking the baby can get the infection. And last is cost. So these are few concerns which we are encountering by parents. So we can counter these concerns by doing counseling. So if we are having very good counseling, so majority of patients their concerns can be, we can answer their questions and we can explain them the benefits of newborn screening.
And in fact, my second question was around heel prick test, because it will look very concerning for parents to get the heel pricked of a newborn baby, and you might often encounter refusals that we don't want to do that. So how do you approach those conversations when a parent will tell you that I don't want to get the heel pricked for my newborn 10 hours old baby? So how do you do that?
Right. So these refusal rates vary in different areas because of their cultural beliefs. And the second important is, if we are doing a very good counseling, if we are explaining the process well, we can reduce it to a significant low level. Okay. Second important issue, we should, when we are counseling the patient, we should first acknowledge their concerns and we should validate their concern. After that, we should explain why we are advising this test and what is the benefits of this test, and we should take some measures to minimize the pain, like we can collect the blood sample when the mother is breastfeeding the baby, so that we can minimize the pain by doing that, these methods. And we should emphasize on the benefit. If any patient comes positive, the what are the benefits that they will get for their entire life. So by doing these counselings, we can reduce the rate of opt out.
Got it. So, in fact, there might be some misconceptions also going around the community about newborn screening or in general genetic screening, not just in the families, but also in many physicians or doctors for that matter. Are there any such common misconceptions about genetic screening?
Right. So first and foremost is, a majority of people think that NBS is a diagnostic test. So it's not a diagnostic test, it's just a screening test. We are just screening a baby for a potential serious condition. So second important is, NBS detects all genetic disorders. So I've seen in my practice, whenever a patient is coming to me and they are diagnosed with some other genetic disorder later in the life. So whenever my team is asking that, have you undergone the parents used to tell that we have done the newborn screening at birth, then why this condition was missed initially. So that's a really a misconception that NBS detects all genetic problems. And next is, it is only for high risk babies. So this is also a misconception. It is not for only high risk babies. We should screen each and every newborn. Then privacy concern. Few of the patients are having privacy concern that their data will be in the public domain, or that their data will be with the hospital, and how it will be stored. So that's again a concern.
Yeah. And finally, there might be some parents who are very, very proactive and very much aware that during pregnancy itself, they might try to understand it if there are any process for screening right before or after delivery. Do you get such questions in your hospital? And if yes, then how do you encounter them?
Yes, nowadays we are getting lots of query. So majority of families in their third trimester of pregnancy, majority of parents, they are asking for newborn screening. And even nowadays we have seen that even the gynecologists, those who are obstetrician and gynecologists, they are also counseling for newborn screening. So there is raised awareness about newborn screening, and these proactive parents are getting information in third trimester of pregnancy, and they are opting in for newborn screening at birth. So
Yeah.
so they are asking that this hospital is offering newborn screening for all the babies, and what panel you are doing to screen the baby, how it will be collected, whether what will be the cost, whether it is mandatory or it's optional. So all these questions we are getting nowadays.
Which shows that awareness is increasing in the society, but we need to pull up our socks and make more efforts to for these kinds of awareness. So since we have touched upon the parental concerns, let's take a moment to understand the process, the screening process itself. Why is newborn screening performed so soon after birth, that is like in the window of 0 to 48 or 72 hours of life? Is it possible to perform this screening beyond this window?
Right. So I would like to say that late screening is always better than no screening. Okay. So late screening is always better than no screening. So ideal time of screening is 24 to 48 hours, or before discharging the baby from hospital. The importance of this period is because when the baby is born, so they start their metabolic machinery. So baby, the metabolic machinery, initial 24 hours, the baby will having metabolites from mother also, and after 24 hours, newborn's machinery starts taking charge. And then if we are and then second important is breastfeeding. So majority of patients, when they are started on breastfeeding, they will be having metabolites more after starting the breastfeeding. And the and it's a pre-symptomatic window. So the importance is if we are diagnosing this patient in pre-symptomatic state, we can prevent irreversible neurological damage, and we can prevent the death in these babies. Like I will give you an example, like sudden infant death syndrome. So sudden infant death syndrome is a condition when we found baby suddenly dead, suddenly. So these patients, when evaluated, they found that fatty acid oxidation defects are a very common cause of sudden infant death syndrome. So we can prevent these consequences for family. So
So,
the last part is the late screening is always better than no screening. So we can screen these babies at any age. Okay, whenever the parents are coming and they want to opt for screening, we can do the screening.
got it.
The
And
best time is,
so this
but the
new
best time is 24 to 48 hours.
got it, got it. So this newborn screening does it detect every genetic disorder, or there are certain disorders or conditions that screenings cannot detect?
Yeah. So no, we can't detect all the genetic disorders right now. Right now. So condition which can't be detected by newborn screening includes like anatomical or structural birth defects. So we can't do by blood spot screening. We can do by the examination. Second important is many chromosomal abnormalities, because many chromosomal abnormalities are having structural issues. So they don't have a biomarker, they don't have a metabolic marker. So we can't detect these disorders by newborn screening. Then many single gene disorders which are having late onset symptoms which are not included in newborn screening panel yet. And then genetic susceptibilities like cancer susceptibilities for diabetes, we can't detect these disorders by newborn screening. And last is when there is absence of biomarker, so disorders without a known reliable biomarker, we can't detect these disorders in newborn life. So that's why nowadays there is a debate going on whether newborn screening should be done by the genetic testing. So we should have a genetic panel. By that we can do the genetic screening. So we can encounter the problem, last problem, when we don't having any biomarker.
Got it, got it. So, since we have talked about the process, the consents, everything, but there is a very critical question to the entire structure of genetic screening or newborn screening, and let's move to that. So, what happens after there is a positive case?
Right.
What do you do after that? What
Right. So
predictions exist? Yes.
yes. So now I want to emphasize the importance of newborn screening program. So newborn screening is not just a test; it is a program. So it includes sample collection, sample transportation, report generation, report communication, and treatment and follow. So it includes everything. So whenever we are getting a positive newborn screening, a presumptive positive report, we should immediately call the family, and or genetic counselor should immediately call the family. They should ask them to come for an examination. It should always be followed by confirmatory testing. We should send the confirmatory test. If confirmatory test is positive, we should refer these patients to a specialist center, and center should give them a management plan and follow protocol. If in few disorders, it will take some time to get a confirmatory report. So by the time we are getting the confirmatory report, we should have a close watch on the baby, and we should give the empirical treatment to these babies till we get the confirmatory report.
Got it, got it. So, and what role does the healthcare providers and families can play in managing these conditions apart from monitoring the child or these things?
Right. So healthcare providers should guide the family regarding the treatment plan. What are the consequences if we are not giving the treatment and we are not coming for the regular follow-up? And the caregivers, they are having their responsibility of having strict compliance to the treatment plan and follow protocol.
Great. So since you also mentioned in your slides about the economic burden of rare disease, which was like quite exorbitant. So how accessible are treatments for rare diseases in India? That's a major question I think everybody would like to ask, like what after screening? Yes.
Yes. So this is the biggest challenge. This is the biggest challenge. Accessibility to treatment is really a biggest challenge. But for few category, I will give an example. Like inborn error metabolism are categorized into three major category: small molecule diseases, complex molecule diseases, and energy deficient disorder. So in for small molecule diseases, we are having very good treatment options like metabolic diets. We can have a dietary changes. We can have a vitamin or cofactor therapies. For few of the disorder like lysosomal storage disorder, there are enzyme replacement therapy which are available. Gene therapy is now being available for few of the disorders, but supportive and symptomatic therapy should be given in all the patients. So we can give the supportive and symptomatic therapy for all the patients. That doesn't cost much. And second important, we can counsel this family to prevent recurrences in subsequent pregnancy, because I will give an example of DMD. In DMD, the average age of diagnosis is 4 years. 4 to 6 years. So majority of patient, when we are diagnosing this patient with DMD, that family already had a second baby. Okay, and second baby is again suffering from the same disorders in majority of these family, because the recurrence risk is 50% in male child
Okay.
and overall 25%. So that's the important of, there is importance not only for the treatment but also for the preventive strategies. And for treatment, definitely we are still struggling to get a low cost therapies for majority of genetic and metabolic disorders.
Okay. So now, since we are approaching towards the end of the webinar, I would like to ask you one last question, at least from my side. How do you see the public-private sector collaboration? And how do you think that they can together help to scale up and strengthen the newborn screening programs in India? How do you think that
Right.
we can do that together?
Right. So public-private partnership is not only helpful, but it is essential to achieve universal newborn screening program in India. The reason being, the public sector is having there some strengths. Like public sector, government can provide the scale and reach. So any program to having a good reach and scale, we need government inputs, government efforts. Second important is policy and mandate. So only government can make the policy and they can make it mandatory for the population. Then trust and equity. There is definitely a huge trust for the government organization is in India. Across the country, majority of patients, they trust government and they follow their policies and their mandates. Similarly, private sector like companies, hospitals, and diagnostic companies. So they are having technology and innovations with them. They are having state-of-art testing facilities, testing platforms, equipments, and new screening assay, which are not available in the majority of government sectors. Second important is efficiency and logistic, which is very important. So it is already seen that the private institutions are more efficient and they are having better logistics as compared to the government institutions currently. So they can provide their expertise in sample collection, sample transportation, and rapid result turnaround time, and the technical expertise, which is again very important. So training for healthcare personnel and robust quality assurance program is very good with the majority of private organization in country. So to have a successful model of universal newborn screening program, the government mandating the policy and managing sample collection through its network, while accredited private labs can handle the high throughput testing, data management, reporting, and often a pre-negotiated subsidized cost.
So yeah, it was a great discussion. But and since you also touched upon the importance of regional languages, and we have a great amount of Hindi speaking audience. हमारे बहुत सारे दर्शक और श्रोता हिंदी भाषी हैं और हम चाहते हैं कि बातचीत सभी के लिए आसान और समझने लायक हो. तो डॉक्टर प्रियांशु, आपसे अनुरोध है कि आपने जो भी हमें बताया अभी तक उसमें से कुछ प्रमुख बातें क्या हम हिंदी में हमारे दर्शकों को समझा सकते हैं?
हाँ, बिल्कुल। सो सो राइट, आपने बिल्कुल सही कहा कि जो मेजॉरिटी ऑफ हमारे दर्शक हैं वो हिंदी को बहुत अच्छा समझते हैं, और हिंदी एक बहुत अच्छी लैंग्वेज है कम्युनिकेशन के लिए, क्योंकि वो उस लैंग्वेज में चीज़ों को एक्सप्लेन करना बेटर देखा गया है कि वो लोगों को बेटर इम्पैक्ट करती है। तो जो आज का ये वेबिनार था उसका जो मुख्य पर्पस था वो पर्पस था कि लोगों को न्यूबॉर्न स्क्रीनिंग की इंपॉर्टेंस से अवेयर कराना। सो सो जो इम्पोर्टेंट पॉइंट है वो एक पॉइंट है कि आईसीएमआर ने जो अपनी रीसेंट जो डायग्नोसिस के जो टेस्ट लिस्ट है, जो असेंशियल डायग्नोसिस लिस्ट है, उसमें न्यूबॉर्न स्क्रीनिंग और साथ में इम्पोर्टेंट मेटाबॉलिज्म की टेस्टिंग को इंक्लूड किया है, जो कि एक बहुत ही इंपॉर्टेंट स्टेप है न्यूबॉर्न स्क्रीनिंग के इम्प्लीमेंटेशन के दिशा में। सेकेंड इंपॉर्टेंट है कि न्यूबॉर्न स्क्रीनिंग भी अलग अलग तरह का होता है। एक तो होता है हियरिंग स्क्रीनिंग, एक होता है कंजेनिटल हार्ट डिजीज का स्क्रीनिंग, एक होता है ब्लड स्पॉट स्क्रीनिंग। जो ब्लड स्पॉट स्क्रीनिंग है वो बहुत महत्वपूर्ण है, क्योंकि वो एक ही समय पर आपको उस एक समय पर कुछ ही बूंदे जो खून की लेकर के वो बहुत सारे डिसऑर्डर्स, जो मोर देन 50 डिसऑर्डर्स के बारे में जन्म पे ही पता लगा के बता सकता है। और इन बीमारियों का अगर हम समय रहते इलाज करते हैं तो हम इन इन बच्चों की जिंदगी की गुणवत्ता को बहुत बेहतर कर सकते हैं। हम उनके अंदर न्यूरो डिसेबिलिटीज, न्यूरो डेवलपमेंटल इश्यूज और डेथ को प्रिवेंट कर सकते हैं। इसी के साथ एक बहुत महत्वपूर्ण बात यह है कि हम इनका समय पे ट्रीटमेंट शुरू कर सकते हैं। इनको सिम्टोमेटिक सपोर्टिव ट्रीटमेंट दे करके हम इनकी क्वालिटी ऑफ लाइफ को बेटर कर सकते हैं। साथ ही ऐसे परिवार जहां पर कोई भी बच्चा किसी जेनेटिक या मेटाबॉलिक बीमारी से सफर कर रहा है, हम उस परिवार में अगले बच्चे में प्रिवेंश रिकरेंस रिस्क को कैलकुलेट कर सकते हैं और उसमें बीमारी को प्रिवेंट कर सकते हैं। तो इसलिए ये बहुत इंपॉर्टेंट है कि आप न्यूबॉर्न स्क्रीनिंग के बारे में जानें। दूसरा है पॉलिसी मेकर्स के बिहाफ पर, पॉलिसी मेकर्स को जो कॉस्ट कंस्ट्रेंट है, अगर हम इसको ठीक तरीके से जानेंगे तो हमें पता चलेगा कि जो जो इन्वेस्टमेंट अगर हम न्यूबॉर्न स्क्रीनिंग करते हैं तो हर 1 रुपये इन्वेस्ट करने के बाद हम 10 रुपया बाद की लॉन्ग टर्म हेल्थ केयर में बचा सकते हैं। तो जो पॉलिसी मेकर्स हैं उनके उनके लिए बहुत इंपॉर्टेंट है समझना कि ये एक इन्वेस्टमेंट है। दिस कैन गिव ह्यूज रिटर्न, 10 times रिटर्न इन फ्यूचर।
दिस वॉज ये मुझे हिंदी में ही बोलना चाहिए। ये आपने जो हमें ये समझाया अबाउट न्यूबॉर्न स्क्रीनिंग, मुझे लगता है कि हमारे दर्शक जो भी हिंदी में समझना चाहते हैं, एंड इनफैक्ट सिर्फ दर्शक ही नहीं, हम ये मैसेज बहुत दूर तक, मतलब रूरल एरियाज में भी पहुंचाना चाहते हैं, एंड इसके लिए आपका बहुत बहुत धन्यवाद कि आपने हिंदी में हमें ये समझाया। And that actually brings us to the end of the webinar. But before ending the webinar, I would like to take some couple of questions that have been asked by the audience. First of all, thank you, audience, for being so patient and in listening about the various details that Dr. Priyanshu has just mentioned and taken us through the through the entirety of newborn screening. So I'll ask the first question, which is by Keshika Chetri. If I'm pronouncing your name, sorry if I'm not saying it rightly. So you are saying that you are new to the field of genetic counseling, and you would like to elaborate on the special paper used for newborn screening, because she mainly takes blood samples. So can you tell us anything about that? She wants to know about the special paper used for newborn screening.
Right. So that's filter paper. That's filter paper. Yeah. So the filter paper, we can we use that filter paper to collect the blood sample. It absorbs the blood, and that blood can be stable. It can have a metabolites which remains stable till we transport it to the lab. And if we keep it a specified temperature, we can keep it for a longer period, also for months.
I think Ms. Garimarana, your question is also covered in this, that because she's asking what is the special paper made up of.
Yes, it's filtered.
Yeah. So so I'm moving on to the question from Mr. Sahil Bose. He's asking that how can early detection of genetic disorders help in reducing the overall economic burden when the cost of genetic testing itself adds to the healthcare expenses?
Yes.
So you have covered it in your talk, but yes, you can still.
Right. So very good question. Very good question. So I will give an example, like congenital hypothyroidism. So you know that congenital hypothyroidism prevalence is around 1 in 800 to 1 in 1000 in different studies in India. So if we rear a patient with congenital hypothyroidism, it is seen that अगर आपने congenital hypothyroidism के बच्चे को पहले 14 दिन में डायग्नोज नहीं किया और आपने 14th डे के बाद डायग्नोज करके ट्रीट किया, तो उसका इंटेलेक्चुअल जो IQ लेवल है वो हमेशा के लिए कम हो जाता है। तो अगर हम देखें कोई IQ अगर किसी का आईक्यू कम है और अगर हमने फर्स्ट 14 डेज में डायग्नोज करके उसका ट्रीटमेंट अर्ली शुरू कर दिया तो उनके आईक्यू स्कोर्स बेटर देखे गए, इट्स प्रूवन। सो अगर हम देखते हैं कि एक जो कम आईक्यू का बच्चा है जो फैमिली के लिए बर्डन पोज करता है उसकी एजुकेशन में, उसकी लर्निंग में, उसकी जॉब में और उसकी प्रोडक्टिविटी में, that is significantly high as compared to the early diagnosis and treatment. So the drug cost only few hundreds rupees for a month therapy. So and it's available for majority of patients free of cost across the country. So there is a huge difference. Similarly, if we'll talk about the small molecule diseases like propionic acidemia, methylmalonic acidemia, so and these disorders, this patient present intermittently, like इनमें क्या होता है कि जब ये कोई कैटाबॉलिक स्टेट में जाते हैं या इनको कोई इंटरकरेंट इन्फेक्शन लगता है तो इनकी बॉडी में जो कैटाबॉलिक प्रोसेसेस चलते हैं और जो जो इंटरमीडिएट कंपाउंड इकट्ठे होते हैं उसकी वजह से इनको ब्रेन डैमेज होने का रिस्क रहता है, अमोनिया लेवल बढ़ने की वजह से ब्रेन डैमेज होने का रिस्क रहता है। और अगर ये कैटाबॉलिक स्टेट में नहीं जाते हैं तो इनको हॉस्पिटलाइजेशन और ब्रेन डैमेज का रिस्क नहीं रहता है। तो अगर हम देखें कि अगर हम एक बच्चे की आईसीयू केयर पे जो पैसा खर्च होता है अगर हम देखें तो अगर कोई प्रोपियोनिक एसिडीमिया का बच्चा है वो प्रॉपर्ली मैनेज नहीं है, उसको इमरजेंसी लेटर्स नहीं दिए हुए कि ड्यूरिंग इमरजेंसी क्या करना है उसे, अगर उसको फीवर आता है वो कैटाबॉलिक स्टेट में जाता है तो वो आईसीयू में लैंड अप होते हैं। और एक आईसीयू केयर के अंदर जो उस फैमिली का खर्चा होता है या गवर्नमेंट रिसोर्सेज जो खर्च होते हैं वो कई गुना ज्यादा है एज कम्पेयर टू अगर हम उन्हें ऑलरेडी प्रिकॉशंस बता दें कि जैसे ही वो कैटाबॉलिक स्टेट में गया तो उनको ये दवाइयों का डोज बढ़ाना है और उसको आईवी फ्लूइड शुरू करना है immediately. So these are just few examples. There are a lot of different examples कि हम किस तरह से हेल्थ केयर पे कॉस्ट कम कर सकते हैं एंड वी कैन हैव ए लॉन्ग टर्म बेनिफिट। जस्ट आई विल गिव एग्जांपल ऑफ इम्यूनाइजेशन, वैक्सीनेशन। हम पूरे कंट्री को वैक्सीनेट कर रहे हैं, हम कितना, और हो सकता है उनको कभी वो बीमारी होनी नहीं थी। कितना पैसा गवर्नमेंट ने पोलियो वैक्सीनेशन पे खर्च किया अक्रॉस द कंट्री, यू नो, उन्होंने घर घर जाके पोलियो ड्रॉप्स पिलाया। बट द चेंज जो अब हम देख रहे हैं वो है कि इंडिया से पोलियो इरेडिकेट हो गया है, लेकिन गवर्नमेंट इन्वेस्टेड hundreds of crores on that immunization program, but we can clearly see the significant benefit अगर हम एक disabled बच्चे को लेके बड़ा करते हैं और उसकी productivity को देखते हैं तो definitely we can have a significant positive proportion.
Yeah, thank you, Dr. Priyanshu, and especially about giving such apt examples about how we can screening can save lives and how it is important for the financials of the entire community for that matter. And I'm taking another question by Mr. Sahil itself. So he's asking another question which says, have you ever encountered a case of sudden infant death syndrome in your career, especially
Yes.
in relation to the babies you mentioned earlier?
Yes. So this is a question which is very close to my heart. I will give a reason. So I joined this institution, SMS Medical College, in 2020. Okay. So when I joined this institution, I was posted in a hospital which was having very high birth rate. वहाँ पर लगभग 900 बच्चे हर महीने पैदा होते थे and I was the only person जो उन 900 बच्चों का राउंड लेता था। ओके, क्योंकि मुझे वो एंटायर पोस्टनेटल वार्ड्स का राउंड लेना होता था। मैंने जब तक वहाँ पर राउंड लिया 9 मंथ्स तक, हमने एक भी बच्चे की डेथ होते हुए नहीं देखी। रीजन बीइंग कि मेजॉरिटी ऑफ सडन इन्फेंट डेथ्स जो होती हैं वो डेथ्स जो होती हैं वो बिकॉज ऑफ अनडिटेक्टेड कार्डियक डिजीजेस और अनडिटेक्टेड सीजर्स और अनडिटेक्टेड हाइपोग्लाइसीमिया होते हैं। वो बच्चों का जो शुगर कम होता है हम उसे डिटेक्ट नहीं कर पाते, उनके कार्डियक डिजीज होते हैं हम उन्हें डिटेक्ट नहीं कर पाते, उनको सीजर्स आ जाते हैं, फिट्स आ जाते हैं और वो सडनली डेथ हो जाते हैं। एंड व्हेन आई लेफ्ट दैट इंस्टीट्यूशन I learned that there was majority of sudden infant deaths in that particular hospital. हम क्या करते हैं कि हम जब बहुत डिटेल राउंड लेते हैं, फैमिली हिस्ट्री लेते हैं, तो हम ऐसे बच्चों को अर्ली आइडेंटिफाई करके, हम अर्ली इवैल्यूएट करके हम उनको निकू में शिफ्ट कर देते हैं, नर्सरी में शिफ्ट कर देते हैं। लेकिन अगर हम मिस कर जाते हैं कि कोई कार्डियक डिजीज है, सीजर्स के अर्ली क्लूज को हमने मिस कर दिया, तो ये पेशेंट सडन इन्फेंट डेथ सिंड्रोम से प्रेजेंट करते हैं। हालांकि इसके अलावा कुछ ऐसे भी बच्चे हैं जो बिल्कुल नॉर्मल होते हैं और नॉर्मल होते वो सडन इन्फेंट डेथ में चले जाते हैं। उसमें मैं आपको एक फैमिली का एग्जांपल दूंगा। तो एक फैमिली मेरे पास एडमिट थी 2010 में। उसमें हिस्ट्री थी कि उनके 3 बच्चों की डेथ, सडन इन्फेंट डेथ हुई जिसका कोई कॉज आइडेंटिफाई आज तक नहीं हो पाया। इवन आफ्टर जेनेटिक इवैल्यूएशन, मेटाबॉलिक इवैल्यूएशन, सब कुछ इवैल्यूएट करने के बाद भी उनके 3 बच्चों का डेथ हुआ। और एक रिसेंटली एक फैमिली और अभी हमारे टच में है, जहाँ पर जो राजस्थान और दिल्ली के बॉर्डर पर एक जगह है जहाँ पे कोटपुतली नाम की जगह है, वहाँ की फैमिली है, उनके भी 3 बच्चों की ऐसे सडन इन्फेंट डेथ से सिंड्रोम से सडन डेथ हुई है, और उनको पता है कि 3 मंथ्स में बच्चा ऑल ऑफ ए सडन एक्सपायर हो जाता है। अब वो चौथे टाइम जब प्रेगनेंसी कर रहे तो हमने उनका डिटेल जेनेटिक इवैल्यूएशन किया है। वी आर ट्राइंग टू आइडेंटिफाई द कॉज कि ये सडन इन्फेंट डेथ सिंड्रोम क्यों हो रहा है।
Yeah. And it might be too much devastating for a family to see a sudden infant death where there is no reason attributed to it. I can totally understand their pain. So, moving on. So, we have a question by Miss Pooja. She's asking, what is the sensitivity of a newborn screening? What is false positive or false negative rate?
Right. So it depends upon the test and the condition. So false positivity depends on हम कौन सा डिसऑर्डर स्क्रीन कर रहे हैं, हम उस डिसऑर्डर्स के कट ऑफ क्या रखे हैं। ऐसा ऐसा माना जाता है कि टू हैव ए सक्सेसफुल न्यूबॉर्न स्क्रीनिंग प्रोग्राम वी शुड कीप द कट ऑफ। जैसे फॉर आई विल गिव एग्जांपल लाइक गैलेक्टोसीमिया। सो गैलेक्टोसीमिया को जब हम स्क्रीन करते हैं तो हम टोटल गैलेक्टोज लेवल देखते हैं। हम गैलेक्टोज लेवल क्या रख रहे हैं हमारे स्क्रीनिंग में, कट ऑफ क्या रख रहे हैं, उसके ऊपर डिपेंड करता है कि हमारे कितने फॉल्स पॉजिटिव आएंगे या कितने हमारे ट्रू नेगेटिव आएंगे। ओके, ट्रू नेगेटिव आएंगे। अगर हम कट ऑफ बहुत ज्यादा हाई रखेंगे तो अगर हम कट ऑफ तो हम बहुत सारे पॉजिटिव केसेस को मिस कर सकते हैं। ओके, तो इसलिए हम उसमें कट ऑफ को लो रखते हैं ताकि हम मेजॉरिटी ऑफ केसेस को आइडेंटिफाई कर पाए। तो इसलिए ये डिपेंड्स अपॉन द टेस्ट, इट डिपेंड्स अपॉन द बायोमार्कर या मेटाबॉलिक मार्कर जिसको हम स्टडी कर रहे हैं। और तीसरा है कि हमारे पास जो अवेलेबल कट ऑफ वैल्यूज हैं वो क्या है। और ऐसा होना चाहिए, आइडियली होना चाहिए कि जब हमारे पास डेटा इकट्ठा होता है हमें जो स्क्रीनिंग का और कंफर्मेटरी टेस्ट का, तो हमें वापस से अपनी कट ऑफ को रिवाइज करना चाहिए डिपेंडिंग अपॉन द पॉपुलेशन और एरिया जहाँ पर हम लोग ये न्यूबॉर्न स्क्रीनिंग टेस्ट कर रहे हैं। I hope I am clear. I hope I am clear.
You're very clear, and the participants can also write in supplementary questions if they are not clear. So, Ms. Pooja has written that very well explained. So, good. So, and there is another question by her that what are the possible factors for neonatal deaths apart from genetic causes?
Right, right. So one is undetected cardiac diseases. जो cardiac issues हैं उनको हम अगर detect नहीं कर पाते तो है। एक definitely infection is still one of a very common cause of death. And next is hypoglycemia. Hypoglycemia दूसरे causes से हो सकता है, poor feeding की वजह से भी हो सकता है कि अगर mother feeding नहीं दे पा रही है। Again then birth asphyxia, prematurity, these are very common causes of neonatal deaths.
Yeah, so I think there are no more questions now, and in fact we are a couple of minutes post one as well. So let's now pause and give a thank from the entire team of Genomiki Solutions and the entire audience. We should thank you, Dr. Mathur, for sharing such wonderful and beautiful insights, both technical, clinical, or in fact also personal from the parental point of view about the newborn screening in India, and also bringing about various thoughts on the newborn screening public programs or the government missions that are being conducted in the country. If any of the participants would like to revisit today's session, or if somebody has not been able to join, the recording will be available on YouTube and we'll be sharing the links pretty soon. Please stay connected for more such initiatives. And with that note, I would like to end this webinar. Thank you, Dr. Priyanshu, for such wonderful discussion, and thank you, the entire audience. Thank you for being here, and let's keep you posted with such more engaging webinars. We are going to conduct a lot of such webinars very frequently now. Thank you, everyone. Thank you, sir.
Thank you. Thank you very much, Genomiki Solutions, especially Diksha, for organizing today's informative webinar.
Thank you, sir. Thank you. And you have conducted it, you have presented everything in a very detailed and insightful way. And thank you so much again. And thank you, audience, for the lovely questions. We'll see you again pretty soon. Thank you. Thank you, everyone.
Thank you.